Upper respiratory tract infections. The common cold. The common cold is the most common illness in children, and 90% of your patients in the clinic will present with a cold. The problem with the cold is that it's a virus and doesn't affect just one area. Its effect is spread out all over the body. So the patient may present with a headache, a fever, a runny nose, a cough, sneezing, and maybe a sore throat. It's like a gunshot blast, causing a headache, fever, runny nose, cough, sneezing, and sometimes a sore throat. In common colds, or as a general rule in pediatrics, the first thing you should do when examining a child, which will make things a lot easier for you, is to check the throat first. Using a tongue depressor and examining the throat can give you many clues. You can find that there may be some hyperemia in the throat, meaning that the color is not uniform, and that there is some congestion, giving a sore throat. So, what is the treatment? The first thing, since there's a fever, we want to use one of the 3 analgesic anti-pyretics. We can use paracetamol before 6 months, Brufen after 6 months, and diclofenac after 1 year. The child's nose is runny, and this is due to vasodilation or congestion of secretions. So how can we go about treating this? We must use either local and or systemic decongestants. Local decongestants can be used before 6 months, and those include things such as baby saline. And after 6 months, we can use pediatric drugs such as Afrin or Otrivin pediatric drops. The dose will be 2 drops per nostril before feeding by about 10 minutes, every 8 to 12 hours. Otrivin can be used every 8 hours, while Afrin can be used every 12 hours because it has a prolonged action. We want to give this decongestant before feeding because one of the mother's main complaints is that because of the cold, the child is unable to eat. But one thing we must remember is that we can only use the local decongestant for a period of no longer than 5 days. This is to avoid due to atrophy because of prolonged constriction, leading to decreased blood supply and atrophy of the nasal vessels. So before 6 months, you can use regular baby saline, which is basically just salt water. And then after 6 months, you can use Afrin and Otrivin pediatric nasal drops. Now, with systemic decongestants, we use them after 1 year. And one thing we have to remember is that it is contraindicated in bronchitis and bronchial asthma. So we use only systemic decongestants that contain pseudoephedrine or phenylephrine in pediatrics. We don't use aminophylline because this causes the child to cry at night for no apparent reason. Children with asthma who get colds should take a bronchodilator instead. One important thing you must remember is that antibiotics don't work on colds. So how do we decide if we're going to use an antibiotic or not? Well, there are a few things you can look at. The first thing is the appetite. The second thing is the activity. Remember, however, if the child is less than 3 months or has had a fever for more than 48 hours, you should probably start them on antibiotics. allergic rhinitis, or the continuous cold. In this case, the mother complains of a continuous cold with a runny nose almost all year round. You must ask about past family history of atopic diseases, such as atopic dermatitis or allergies and bronchial asthma. Make sure to ask about other family members. The first thing we recommend is to avoid exposure to precipitating factors. Avoid things such as dust, bananas, strawberries, etc. Most children are resolved by age 5 to 6. There is, however, a small chance, though, that this allergy or rhinitis may be present for life. So avoid cleaning and dusting in front of the child. Treatment of allergic rhinitis. This is an allergy, so we want to use antihistaminics. One of the most common is phenestyl, which is safe from the first day of life. This is safe and and what we can use before 6 months. After 6 months, you can prescribe Telfast and Zyrtec. And after 1 year, you can use loratadine or mocidine or Claritin. If you want to be extra cautious, though, you can wait and only use phenestyl up until 2 years. After that, you can use the others. So what's the dose of these antihistaminics? Well, for syrups, again, it's 1/3 of the way before sleeping. Drops, it's 1 drop per kilo before bed. Phenestyl, however, is safe enough for you to take 3 times a day, but the rest you should take only once before bed. The other drugs are long-lasting, so that's why it should only be taken 1 time before bed. There are other medications we can use other than antihistaminics. Since this is an atopic disease, we can also give nasal corticosteroids after 6 months. We can also use mast cell stabilizers after 6 months for prophylaxis. This is especially helpful and useful in the springtime when there's a large incidence of hay fever. So what we want to do for allergic rhinitis is to use antihistaminics, and if the child is older than 6 months, we can use nasal corticosteroids and mast cell stabilizers. Sinusitis, or inflammation of the sinuses. When to suspect sinusitis? This may occur if there's overproduction of secretions or discharge or congestion, which results in the closure of the nasal openings of the sinuses. When the opening is closed, the secretions in the sinus will be trapped with no way for them to be drained. So this results in infection of the sinuses with fever. Symptoms of sinusitis. Sinusitis should be suspected if there is a prolonged cough, sometimes lasting more than 2 weeks, with no apparent reason. On examination, you find that the child's chest is free or normal. This cough is usually a mild cough, and it mostly occurs in the middle of the night or just upon awakening in the morning. The cough is not continuous, but comes in attacks. One of the telltale signs of sinusitis is during throat examination, there is the presence of a posterior nasal discharge. This discharge may reach the trachea, irritating it and causing the coughing. If the child is old enough, they may relate to you that they have a headache in the facial area. You can ask the patient to lean forward with them face down and see if the pain increases. This may also be elicited by slightly pressuring on the places where the sinuses are. So what do we prescribe for a patient with sinusitis? First, we give an antibiotic, then a analgesic, and also add a decongestant and mucolytic. These are the 2 most important things. The decongestants, local and systemic, along with a mucolytic. The mucolytic will dissolve the phlegm and mucus that is obstructing the nasal openings of the sinus. This is also why we add local and systemic decongestants. First thing is an analgesic antipyretic. We don't need to go over that. You remember that page. Again, it's the same. Second thing is we give a local and systemic decongestion. We've also gone over those before. And the third thing we want to give is a mucolytic, something like Mucogel or Muco. And the dose will be 1/3 of the weight 3 times a day. Last thing we want to give is antibiotics. So, what are the duration of antibiotics? I'll make it real easy for you. Either we have 5 days, 7 days, and 10 days. 5 days for cases of bronchitis, sinusitis, pharyngitis. 7 days for cases like tonsillitis, otitis media, and gastroenteritis. And 10 days in cases of pneumonia, typhoid, and urinary tract infection. So, since this is sinusitis, we give a case of antibiotics for 5 days. So, what are the antibiotics that we can use? The first group we have is penicillins. But can we use these penicillins, such as pencythine and these normal regular penicillins? Well, an upper respiratory tract infection is gram-positive. The problem with the penicillins is although they are gram-positive, they're not anti-staph. So in an upper respiratory tract infection, we need something that is gram-positive and also anti-staph. Therefore, we can't use ampicillin or amoxicillin on their own, as well as just penicillin. We can, however, use ampicillin if it is combined with sulbactam, and amoxicillin if it's added with clavulanic acid. Now, they will be gram-positive and anti-staph. There is also a group of anti-staph penicillins that we can use. The next group of antibiotics we have are cephalosporins. We have first, second, third, and fourth generation. First generation cephalosporins are gram-positive anti-staph. Third generation are mainly gram-negative. And second generation cephalosporins are gram-positive and negative. But we will reserve the fourth generation cephalosporins for cases in the ICU or in cases of septicemia. The next group of antibiotics we can use are aminoglycosides. These are gram-negative injections given every 12 hours for a period of no longer than 5 days. You have gentamicin, which is nephrotoxic, with a dose of 5 milligrams per kilo a day. And you also have amikacin, which is autotoxic, and its dose is 15 milligrams per kilo a day. The next group we have are macrolides. This group is gram-positive, and all are oral. They are very safe, but care should be used in hepatic patients. We have azithromycin, clarithromycin, and erythromycin. Note that all of these three should be taken on an empty stomach, either before feeding or after feeding for 2 hours, 15 minutes before feeding or 2 hours after the meal. Now we have another group of antibiotics called quinolones, which are gram-negative, but these should not be used in pediatrics. We shouldn't use them before 16 years of age. So, what can we use in upper respiratory tract infections, such as sinusitis, bronchitis, tonsillitis, and otitis media? We need something gram-positive anti-staph, so we can use ampicillin when added with sulbactam, amoxicillin when added with clavulanic acid, and anti-staph penicillins. We have also first-generation cephalosporins. And lastly, we can use macrolides, like erythromycin, clarithromycin, or erythromycin. These are all gram-positive anti-staph. So you have 5 groups of antibiotics that are gram-positive anti-staph. So in front of us we have a case of a 1-year-old child weighing 10 kilos with a fever of 39.5 degrees Celsius, presenting with signs and symptoms of sinusitis, a prolonged cough, fever, and posterior nasal discharge. You can subscribe, for instance, paracetamol suppository, 12.5 milligrams, because he's less than 3 years old, for every 12 hours. We also need antibiotics, but most importantly, don't forget the local and systemic decongestants along with the mucolytic. So we can give Ultravine pediatric nasal drops. You can give him 2 drops every 12 hours. But remember, this should only be used for 5 days. Since the child is 1 year, we can also give a systemic oral decongestant like Congestal syrup. Its dose will be 3.5 centimeters. That's a third of the weight, 3.5 centimeters every 8 hours. And a mucus syrup, it's also a syrup, so the same dose, a third of the weight, is 3.5 centimeters every 8 hours. For an antibiotic, we can use any of the 5. In case of sinusitis, we found that it responds very well to macrolides such as azithromycin. So we can give azithromycin suspension of 200. Remember, the dose here in the antibiotics is 10 milligrams per kilogram a day. So the patient will need 100 milligrams. So the dose will be 2.5 centimeters on an empty stomach once daily for 3 days. Why 3 and not 5? Because if you remember the antibiotics, azithromycin is only used for 3 days, and it's only taken for 3 days, but it will stay active for up to 10 days after that. So, if you remember the macrolides, azithromycin is taken once, clarithromycin is taken twice, and erythromycin is taken 3 times. The dose in azithromycin is 10 milligrams, and clarithromycin is 15 milligrams per kilogram, and in erythromycin is 50 milligrams per kilogram. And all should be taken on an empty stomach. The encounter in the clinic is otitis media, middle ear infection. Otitis media is one of the common causes of hidden fever in children. The child may present to you with a fever and clear throat and chest. It is also one of the causes of febrile convulsions, along with tonsillitis and urinary tract infections. So why is otitis media common in children? Well, in adults, the eustachian tube is angled upwards and is longer, while in a developing child, it is horizontal and shorter, making it easier for infections to go from the nose and pass to the middle ear. So usually the mother's complaint in a case of otitis media will be that the child is feverish and she can see him banging on with his hands on his ears while crying. This banging on the ears helps indicate that this is otitis media. The mother may also mention that the child has previously had a cold. That one of the causes that may contribute to otitis media is that the mother may nurse or feed the child while they are laying flat on their back. This makes it easy for the milk or the food to pass through the eustachian tube to the middle ear. So what you must tell the mother is that she should nurse or feed the child while they are laying at a 45-degree angle. Now, the prescription for otitis media should include an analgesic, antipyretic, an antibiotic, and a local and systemic decongestant. Decongestants are important to opening up and clearing the eustachian tube to allow the mucus to be drained from the middle ear to the nose. We know the antipyretics and analgesics and the local and systemic decongestants. I don't think we need to go over them again. And we use one of the 5 groups of the antibiotics that are gram-positive and anti-staph. But here, since this is otitis media, the duration is 7 days. In some cases, it's more beneficial to start antibiotics with injections first for 3 days and then continue the rest of the course orally. So, in this case, the child is 2 years old, weighing 12 kilos, with a fever of 39.5 degrees Celsius. And the mother tells you that he is feverish and crying and banging on his ears. After examination of possible other causes, we can prescribe a Voltaren, for example, a Voltaren ampoule, giving 1/2 centimeter for every 10 kilograms. So, in this case, it would be 0.6 centimeters every 12 hours. For the decongestant, you can use Afrin pediatric nasal drops. Give 2 drops every 12 hours for 5 days, remember. We can also start them off with Augmentin 600. Use a vial of 2.5 centimeters every 12 hours intravenously for 2 to 3 days, and then continuing with the same type of antibiotic. So we can use Augmentin 230 suspension and give them 4 centimeters every 8 hours for a period of 5 days. Tonsillitis. Tonsillitis usually does not occur before 1 year of age. It is important to differentiate between the cause, if the cause is viral or bacterial. If the tonsillitis cause is viral, there will be a low-grade fever with good appetite and normal activity, and therefore it probably won't need antibiotics. If it's bacterial, however, there will be a high-grade fever, and the child will look and appear toxic and exhausted. They will have poor appetite and poor activity. Examination of the throat may reveal congested tonsils with pus. The problem with the pus here is that the child may swallow it, which will cause irritation of the stomach and vomiting. And the vomiting may be the presenting sign. This is why we usually examine the throat first. As in this case, you may be confused with gastritis. If the patient is first coming to you with vomiting, you may first think gastritis. So that's why we check the throat first, because it can help you quickly differentiate from other things. So in this case, we will find congested tonsils and pus on the tonsils, and when the child swallows the pus, it will irritate the stomach, causing them to vomit. Treatment includes analgesic antipyretics and antibiotics. The antibiotic duration should be for 7 days in tonsillitis, and we can choose from the group of gram-positive anti-staph antibiotics. So a prescription for a 1-year-old weighing 10 kilos with pus on the tonsils and a fever of 38.5 degrees would look something like this. You can give them Brufen syrup, 3.5 centimeters every 8 hours. A Duracef 250 suspension. Here the dose is 1/2 for every 10 kilos. So it will be 5 centimeters every 12 hours for a period of 7 days. One thing that may appear on throat examination are adenoids. The adenoids grow normally from ages 2 to 4 years. If they grow or this occurs before that, they may lead to nasal obstruction and suffocation. An adenectomy can be performed from 5 months, but it's preferred not to, as there is a recurrence rate of 50%. So treatment will include analgesic antipyretics, giving a local nasal decongestant and using an anti-edematous such as maxilase syrup. This anti-edematous dose will be a third of the weight every 8 hours. Stridor. Another condition you may encounter in a pediatric clinic in upper respiratory tract infections is stridor, which might seem alarming to you. This is a serious condition. Whether viral or bacterial, it may be more dangerous than meningitis. The child would present with inspiratory sounds, and these sounds occur when the child is taking his breaths. This must be differentiated from foreign body inhalation, which can be done through, first, the history taking. Has the child been playing with small toys, such as marbles or small plastic toys with small plastic pieces? Has he been eating peanuts or anything with seeds? Something like that. Here, the sounds will be tracheal and not affecting the voice, and the child should be referred to an ENT specialist in this case. The most important thing in suspected cases of stridor is not to use bronchodilators or a tongue depressor. The child is already having trouble breathing, and giving a bronchodilator will just make things worse. Using a tongue depressor may cause shock and may be fatal, especially if there is acute epiglottitis. In acute epiglottitis, the child presents with severe upper airway obstruction, high-grade fever, opening of the mouth, protruding of the tongue, and dribbling of the saliva and leaning forward. Treatment of stridor involves giving adrenaline with a nebulizer. You use 1 ampoule of adrenaline on 2 centimeters of normal saline. Since stridor is considered a type of allergy, so we want to administer also corticosteroids intravenously or intramuscularly. You can use Solucortev, Dexa, and give us 1 centimeter for every 10 kilos every 12 hours. If this fails, you can give adrenaline subcutaneously. You do this by diluting 1 ampoule of adrenaline with 9 centimeters of regular saline, and give 1 centimeter of this solution for every 10 kilograms using an insulin syringe subcutaneously. If this doesn't work, the child should be hospitalized. Treatment at home is as follows. It involves in giving antibiotics, one of the 5 gram-positive anti-staph that we know, with a short course of steroids, giving apidone or fendone or vendexin, a third of the weight every 8 hours. You can also give something such as a Vapozol inhaler and have the child inhale steam by adding 5 centimeters to 200 milliliters of boiling water and having the child inhale the steam.